Welcome, everybody, to the latest episode of the Interventional Endoscopist podcast. I'm your host, Munkapil Suchdev. Today, I have the honor and pleasure of interviewing Dr. Jessica Widmer, who's a good friend of mine and somebody I got to know through FIGHT. We're both on the ERCP committee, and we worked together for about 3 or 4 years now. So, Jessica, welcome. Thanks for joining us.
Yeah, thanks for having me.
All right. So, as I mentioned, we got to know each other through. Excuse me. We got to know each other through the FIGHT committee. And so tell me a little bit about yourself. Where are you right now and what's your role?
So I'm currently at NYU on Long Island. It's the hospital. I refer to it, as the hospital formerly known as Winthrop. Many people know of it as that old name, but it's an NYU hospital now. And I've been here for about 9 years, almost 9 years. However, I did my residency and fellowship here, so it's really what's coming home for me. And since I've been here, I've had a few roles. Initially, my first leadership role was as Chief of Endoscopy and the Advanced Endoscopy Fellowship Program Director. But about 2 years ago, I took over as the Chief of the division.
Oh, great. That's awesome. And so you did fellowship and residency there. Where did you do medical school?
So I grew up outside of Pittsburgh, small town in southwestern Pennsylvania. And then I went to Philadelphia College of Osteopathic Medicine. I met my husband there, who is a New Yorker. He grew up on Long Island. And so we couples matched together. We decided to kind of take the plunge, and we did internal medicine residency together. And he is a cardiologist, so we matched in our respective fellowship programs together. And then I kind of threw off our schedule and decided to do an interventional year, and he got a job. And I did that I did my interventional fellowship at Cornell. When, my husband was very happy in his job. He's still in the same job since fellowship. And so, that kind of dictated where we were going to be geographically. So we stayed here on Long Island, and I was with the neighboring health system for about 4 years before the position here opened up, and I came back.
Awesome. Yeah. My wife and I, we did residency together, but there was 1 week, actually 3 days specifically, where I was her resident and she was my intern.
Oh.
Probably the 3 worst days of my life.
I have some stories.
Yeah, imagine teaching your wife how to do a thoracentesis, and it did not go well. Or husband, I should say. So anyway, okay. And so you said you grew up outside of Pittsburgh. So and then what kind of influenced you to become a physician in your childhood? Were there any specific influences, people or events that kind of led you towards medicine?
Yeah, I mean, it's interesting. I would say I grew up in a very small town that, in retrospect now I realize that it was probably, it's a poor county in Pennsylvania. I wouldn't say that there's a lot of educational opportunity there. I'm not really sure why I decided specifically to tell everyone from a young age that I was going to be a doctor. I thought it sounded great. But that's truly, there's not a good reason. I ended up going in that direction. But I would say that I was influenced by my primary doctor as I got older. She was a woman doctor, in this small community. And when I saw her, she just treated me with respect. I remember very distinctly, I think I was like 12 or 13, and she was, spoke to me like I was an adult and explained certain things to me, and it just caught my attention. And I really followed in her footsteps. She tried to convince me not to go to med school. She tried to tell me how difficult it would be and the challenges with medicine. And, it was one of those things where you have to like knock on the door 3 times until they realize you're really serious and not going away, But she really opened doors for me.
That's awesome. And then when you got into medical school, what kind of pointed you towards internal medicine and ultimately gastroenterology? Were there any specific medical school or residency influencers that are, I guess, role models that you had?
I would say forever I wanted to be a surgeon. I mean, I was like the teen, I was like in my study hall, dissecting animals, in my free time. And I really always wanted to be a surgeon. I think once I got out into my rotations, I think it was just a specific, interaction. I think if I was with surgical oncology or something, it would have been different. I was with like just a vascular surgery group and I was not engaged at all. And I started rethinking what I was doing.
Mhm.
And so I knew I wanted to do something procedurally based, and I was kind of thinking I'm bored by radiology. I didn't think I could get through radiology to get to IR, and I thought, oh, maybe GI. So I went in that direction. I think just also had some good experiences with electives and people I connected with. Uh, But really, I heard a lecture. I heard round rounds during an interview on notes, and I was like, oh, this is what I want to do. I was like very interested in that. And as I was in my residency, I connected with this really nice young woman in GI, and she took me under her wing, and I'm very grateful for that. But it's sort of a funny story that she's a motility specialist, and I would go to her clinic with like a heavy heart, and I'm the best patient for you. And like my heart would sink. And so it wasn't exactly where I saw myself going. But then, one of my mentors, he came and rescued me from motility, I would say. And, he just really was doing some crazy stuff at the time, or at least I thought crazy stuff that I fell in love with. He was doing cholangioscopy with gastroscopes. He was doing therapeutic EUS, biliary and pancreatic duct drainage. And I was like, this is fascinating. I definitely have to do this. So that's really how I made the decision to do interventional GI.
Oh boy. Okay, sorry about that. My phone rang. Okay. And any specific person that you want to shout out to?
Sure. I mean, that was everybody knows him, Stavros Stavropoulos. I got to see what he was doing early on in my residency, and definitely is the reason why I'm here where I am, for sure.
No, he's a trailblazer. I mean, a lot of people, he's one of those guys that he's at the forefront of everything on the interventional side, and locally here we have a couple people, or one specifically that's an interventionalist who was trained by him, and the kind of stuff and the thought process kind of passes down. So he's definitely a trailblazer and somebody who's influenced a lot of people. And then is that the reason that was he kind of the person who pointed you towards interventional after general GI fellowship?
Yeah, I mean, I would say I was really following him around from my residency, honestly. And I kind of, um, he too couldn't turn me away. It's always showing up, I loved it. I had my day job and then I had my night job, which was watching all of his cases, because let's get scoped late and, they're just, I would we had an advanced fellow. And so I would say, but what can I do? He let me start teching, like any way that I can be involved in the cases or caring for those patients, I was always on their service, whether I was on their service or not, so it was, a very natural thing.
Yeah, for sure, for sure. And then were there any challenges? Like, I mean, I know couples matching can kind of be a challenge in terms of picking a field sometimes for some married couples or dating couples or whatnot. But like, were there any other challenges that you saw along the way to pick GI or interventional? Anything that kind of roadblocks that you had to overcome?
I mean, just in the sense that GI is a very competitive field. Gosh, I look at the candidates now and I think would I be a gastroenterologist if I was applying now? Well, really phenomenal candidates. No, but I was lucky, I think that I established my role. I stayed in my program, so maybe I was lucky, but I created a situation where they relied on me. So they needed me. They liked having me there. I was, very helpful and resourceful. And I think they saw my work ethic and everything. So I was very fortunate to get my position as husband. We didn't couples match for fellowship just because both were so, you know, uh, competitive. For advanced endoscopy, I decided to leave my program mainly because I think with my early exposure to pancreatic biliary disease and therapeutic EUS, I really loved that, and I wanted to pursue that. And I think, it was the time when Stavros was really getting into ESD and poem, and I wasn't nearly as interested in that. So I I really wanted to focus kind of on therapeutic EUS and pancreatic biliary disease. And so, if being part of Stavros's research, I'd seen a lot of publications by Michel Kahaleh, who is my second major mentor, and I was able to connect with him and lucky to get a position at Cornell working with him. So, challenges with getting positions. I think I was fortunate, really making personal connections. It's really competitive. But I was lucky, I guess.
No, I think we all, we all kind of go through that process too. I look at it as well. When I was reviewing applications, I was like, man, there's just no way I would get into, shoot, I don't even think I would get into internal medicine now. But it's definitely the kids are just getting so much better and so much more well-rounded, and the stuff they're doing is amazing, So was there a specific moment where, like, in your childhood where you felt like, you know, like, I know you mentioned you were following the family doctor, or you met the family doctor, and she really inspired you. But was there anything in your childhood that said, "Hey, I can do this. This is definitely, I know that this is it within my grasp or my reach." Is there kind of one sentinel time in your life where you're like, "I know I want to do this, and I can do it, and I'm going to do it"?
Uh, no. What I'm saying is that I think what I knew is that I wanted to get out of a small town without a lot of opportunity. I'm not sure where that came from inside of me, but I wanted out for sure. I want more opportunity. And I I really probably wanted to be in Manhattan. Um, so I kind of made my way east. But I, so no, I guess there wasn't really a moment. It was more the drive to
Here.
have more in my life, and the drive to kind of get out of small town Pennsylvania.
And it's, I mean, I think you see that a lot. And then you also see the opposite way. People live in big cities their entire lives, and like, you know what, I just want to go to a small town and get away from the hustle and bustle. So it's actually, it's a very commonplace thing to see it go both ways for sure. So if you weren't a physician, what would you be doing?
Uh, for a long, long time, I would say that there's absolutely nothing else. There really isn't. I think that's, isn't that why we're all here? It's not easy what we're doing, but it's who I am for sure. Now as I get older, I mean, like maybe I could be like a travel food blogger. That
Yeah. Instagram food influencer, take pictures of every meal.
I'm not sure anyone would follow me, but
I know a few of those, and they make a lot of money taking pictures of dessert. I mean, it's pretty good. So, all right. Well, so let's talk about ERCP and cholangioscopy, because I mean that was an impetus for you to go outside of your institution. Just for a footnote, or I think it's a great idea was to leave your parent institution, even if you come back, because the more varied training you have, personally, in my opinion, is it's better. I think it's always good to have a hiccup or a away rotation, if you will, or 2 or 3 years away, because you get a different perspective. You bring new thoughts and new ideas instead of everybody kind of doing the same thing from day one to day or year 9 or whatever it is. And so I think it's excellent choice to leave your parent institution for a little bit, even if you intend to go back. So, or not intend, but have to go back. So, But so let's talk about that year. So you saw these cases, you liked ERCP, you went out and you sought Cornell for the ERCP and cholangioscopy experience. So how'd you get started in that process outside of watching those cases, and what's kind of your journey with that?
Well, as I mentioned, I guess the reason why I was so interested is because I saw Stavros going kind of outside of the box. Back in the day, we had, legacy spyglass where you couldn't see very much. Nobody knew what they were seeing. The fiber broke all the time. It was terrible. We were limited with accessories and everything. And so, in larger ducts, Stavros would use either an XP gastroscope or, regular diagnostic gastroscope. And I was fortunate just to be part of a project that he did and submitted to DDW, where we kind of made an outline, an algorithm of, what scope to use, based on what fits in the duct to kind of overcome those limitations. And so the image quality that we saw at that time was spectacular. I mean, I felt like we were doing bronchoscopy, as compared to what we were able to see with Legacy Spy. So that really, I think I just loved the enhanced capability with that. And kind of same thing with therapeutic US, the ability to be able to drain internally, is so desirable for the patients, in addition to an exciting, technically challenging procedure, which I have always kind of loved more complex things in complex patients. But what we were able to offer the patients, I really believed in that. And so that's really why I wanted to pursue that further in my fellowship. And I also think, I was very interested in hands-on opportunities to do that, which led me to working with Michel.
Yeah, for sure. So now you've been doing this for several years. You've gotten pretty good at it. Do you have, for the young interventionalists or the people starting their fellowship, do you have any kind of, how do you get good at it? Like what's a good way to tell a fellow, like, obviously practice, right? We say practice, 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 but like what's a good mindset or a good thing that they should be doing so that they can improve their skills?
Yeah, that's a little bit of a tough question. I mean, I looked at this recently, and actually the learning curve in a small study for cholangioscopy is about 60 cases. I was surprised it was that high. I think there are a lot of centers that maybe the fellows not getting an opportunity to do that many during their advanced fellowship. I think it's not as much the technical difficulty of performing cholangioscopy, but perhaps more so understanding what you're seeing. And so, I would suggest, really, there are so many online things that you can do in terms of training, and I'm sure videos and things like that. So I would suggest tapping into those resources. I think, from a technical aspect, once you're doing, 10, 20, you're really, really getting used to it. I think the big challenge is the distal duct. Obviously, that's a very unstable position. There are a lot of different things you can do to overcome that. But I think the other part of this, and we had an interesting discussion about this at DDW during one of the cholangioscopy sessions, is really, I do think it's our responsibility, not only as the technician, is to not only be a technician, but really taking a lot of time to report what we're seeing and doing. A lot of this is about mapping for the surgeons. I had an interesting case yesterday that was a biliary IPMN. And it was a really challenging, and the patient, I'm not sure there's an underlying cancer there yet. We know it's a pre-malignant condition. So if I don't get a cancer diagnosis, can the patient be resected? And it was at a tough location involving the CHD and the right intrahepatic, right main intrahepatic ducts. And it was really challenging mapping just because of all of the mucin and everything, but how important that is to describe for the surgeons how far I went, what segments that I went into, the extent of the tumor, what's affected, what's not, how far distal does it go. And I think that a lot of people are doing cholangioscopy, but perhaps not reporting the details as well. And I think that's so very important.
And that's actually several great points there. I think, the reporting, we don't have kind of like a standard reporting system for cholangioscopy at this point. And I think that's something that we really need, and in terms of numbers, I remember when I was going to the program directors meetings, we would talk about cholangioscopy, and I got an informal survey together. I asked a bunch of folks and they emailed me, anonymously. None of the fellows at that time, and this is about 5 years ago, were doing more than 15 by themselves, the whole year, and most of them were between 5 to 15 in that range. And that too, we don't know how much time they actually had the scope in their hands, so to speak, the entire time. So it's one of those procedures that early on there wasn't a lot of adoption, and so there's not a lot of experience. There's not a lot of people doing it, and now, I mean, that's changing obviously, but I think having the ability to teach, because you yourself as an attending at the time weren't doing a lot, so the fellows in turn weren't getting that much. But I think that's changing, especially now that you've got not just Spyglass, you've got Dragonfly hitting the market, you've got IMAX hitting the market. So now you have a little competition. You've got 3 different industry partners who are going to be pushing for more cholangioscopy, and then they're going to be talking to the fellows, and you're just going to see it take off. But I think your point about standardizing or reporting and standardizing what you see is really important, because I had a teacher in medical school, and she had this statement that stuck with me, and this is like, I don't know, 25, 30 years later now. But she says the eyes only see what the brain knows, so if you're not reviewing pictures of cholangioscopy, knowing what's abnormal, vascular patterns and nodularity and things like that, you may not pick up on small things. And I think studying that, and then also when AI gets added to cholangioscopy, that's going to be really, really helpful to all of us. So,
Yeah.
So when you do teach cholangioscopy, what's your personal approach as a mentor?
Well, starting out slow. I always teach. No, I'm okay. I always approach endoscopic education kind of on a layering basis, if that makes sense. It's constant, like, I always want the fellow to have their hands on the scope, but it may not necessarily be for the entire procedure. So, in the beginning, I would say all my patients at that point have a complete sphincterotomy, and perhaps I'm starting to teach them to advance the cholangioscope over a guide wire into the bile duct. And really, at that point, I'm just kind of trying to teach them how to go proximally and stay centered, and teaching about what we're seeing, if there's a lesion, versus stones. And I think that's where we're starting, just knowing what you're seeing, trying to do, a good evaluation of the whole duct. And then I think, there are variations of that, as you have a more proficient fellow, they don't need to cannulate over a wire, and you're teaching how to do that. And I think more advanced imaging. And it can be even, a little bit difficult to target your biopsies, understanding how you're passing accessories, sometimes in certain locations it's difficult, and you have to come out and put your forcep out and go back in. All of those little tips and tricks. And then, as I mentioned, I think probably, and really, I don't do laser at my institution. I do EHL, and that's generally pretty straightforward for the fellows, and they love it. So I'll do that early on.
People love watching stuff explode.
Never gets old. But I think the hardest thing is staying stable for a distal lesion, or even a distal stone, and that you're trying to treat, and that is a challenge. But I think what I usually do is, I do most of my ERCP supine, so my positioning is going to be a little bit different than others. But, sometimes I just have the hub of the scope kind of forward in front of me. I'm often pushing in a long position. to try to keep this scope stable. So, those are just some tips trying to keep your position and not fall out.
Yeah, no, to that point, I'm hearing a lot of people now kind of converting to supine. I still haven't joined the train yet. I'm still kind of doing my own ERCPs, but I've been a little bit more open to it the last year, just because I'm hearing that more people are doing it, just easier outcomes, better outcomes, and things like that. But I'm getting there slowly. But yeah, I haven't joined that gravy train yet.
I mean, that's what happens. I was trained by a European. And in the beginning, I said, "Oh, Michelle, this is so much harder." And he said, "That's an urban legend, Jess." It is. It is more challenging. And, I tell the fellows, what doesn't kill you makes you stronger. And I couldn't wait for that text message, a few months out where they say, "I'm so thankful that I learned this." It always comes. It does. But my partners do prone, so it's, I'm unpopular in the beginning. Yeah, so it's tough in the beginning of fellowship, but I think it enhances the skill. I am popular with anesthesia.
Yeah, for sure. No, they love it. I mean, I think the problem we have actually is my lab. I've gone on record saying this, and I will continue to say this until they build me a new one. My lab is probably the worst endo lab in this country, in terms of the equipment, the layout, the wiring's hanging. We have wires zip tied to the ceiling, those type of things. So our monitors are huge. They're like 65 to 70 inches, but they're stapled, like stuck to the wall, so they don't move at all. So for us to get into a supine position, then trying to get the monitor position the right way is the neck pain and everything. Hopefully one day, with some people joining our hospital system, we might get new stuff. But anyway, so, and you're doing pancreatoscopy, correct?
Yeah.
So that being in a more advanced kind of form of biliary imaging, do you remember your first pancreatoscopy? What were kind of thought process? How did you get comfortable with it? I mean, obviously we know doing more of it makes you more comfortable, but kind of talk about your pancreatoscopy journey a little bit.
I can't really remember my first pancreatoscopy, but I'd have to say, and I feel like it was probably in the setting of chronic pancreatitis and pancreatic duct stones. So what I do now is mainly is that not as much for necessarily for stricture characterization, although certainly an indication, but more so for stone treatment. And also, my surgeons are proponents of mapping for IPMN prior to surgery, so I do get asked to do that as well.
That's awesome. And I think with all the mapping stuff, I still don't understand why none of the three manufacturers have put like radio opaque markers like every 1 centimeter on these cholangioscopes, so that we could actually like put it there, take a fluoro image, and say the lesion is 1, 2, 3, 4 centimeters from the papilla. It blows my mind that in 20 years. Oh yeah, because we just had Spy's 20th birthday recently, I guess. So in 20 years of disposable cholangioscopy, no one's thought to put like radio opaque markers on the cholangioscope. So it's like, or some way to measure how far you are up the duct, so that instead of like putting your thumb on the screen saying, okay, about a center, 1, 2, 3, you just
Say that my thumb is a centimeter, so I'm really lucky.
Oh God. I mean, yeah. Anyway, that's just a whole nother conversation. So you do ERCP, cholangioscopy, EUS. So is there a specific interventional procedure that you think that you feel is like your favorite, and that's the one that you never really are exhausted doing? Maybe it's a long day and you got one more of what's your favorite thing that you can be doing case wise?
I don't know, some sort of purulent drainage, right? I get a lust. The funny thing is, I love endoscopy. And I still get a lot of enjoyment over everything. And I think working with fellows is part of that, because I kind of I get refreshed by their childlike wonder every time a stone is practical. My fellow this year, like, he just has such a love for endoscopy, and he's like, "Oh, there's the stone," and I can't help but like be excited also. I don't know. I think you guys get enjoyment out of every procedure, and And I do. I have a love for all of it. But I think what's most gratifying is really when you've made such a difference for the patient. And that could be a simple ERCP for terrible cholangitis, and they turn around and that feels good. You've made a difference for the patient. Or it could be something terribly, advanced and in terms of, say, like a pancreatic biliary malignancy with gastric outlet obstruction. The patient is suffering so much, and we do, a gastroenterostomy, and how grateful that patient is for something so simple as the ability to eat. Uh, those sort of things. It's really, can be a wide variety of procedures for me, but from easy to complex, when we've really made a difference for the patient, that feels good.
Yeah. I think the one thing for me never gets old is putting a stent into an obstruction and then just watching that thick black L just come out, and it's like, I feel like Dr. Pimple Popper, but the GI version. So, well, okay. So kind of going on to being an interventionalist, is there a myth that you have thought about? Like, is there a myth about interventional endoscopy that just drives you, nuts or crazy?
Hmm. Not right off the bat that I can think of. I think actually when you look at what advanced endoscopy was in the past, even 10, 15 years since I started doing it, it's a totally different animal than what it was then. The people doing it are very different. There's a lot more diversity now. There's different, you can have different types of lifestyles, maybe that's what's changed so much.
Yeah. Let me get your thoughts on this then. I mean, I brought this up to Sri Kamanduri and to Neil Sharma and a bunch of other people that have been on the podcast. What do you when I trained, and I think you trained maybe a couple years after me, right around the same time, interventional endoscopy was EUS and ERCP. POEM and ESD were being done by guys like Stavros, but it wasn't kind of mainstream. It wasn't endobariatrics wasn't like a thought in anyone's head at the time. So do you feel like we need to change the way that training happens to where you do general interventional, so to speak, where maybe you do 6 months or a year of ERCP EUS, and then you do an additional training in ESD, POEM, maybe cholangioscopy, I don't know, endohepatology. What is your kind of, as someone who's intimately involved with education, what do you kind of see as being the next steps for this kind of growth in our field?
Yeah, I think we can't do it all. The thing is, why there hasn't been change? Because I feel like we've been talking about this since I was applying for my fellowship. There's not change because we still love to do it all and are still trying to do it all because we love these procedures. We don't want to be boxed in. I think that's a lot of it. But I think we all recognize, we talk about it in fellowship interviews and fellows talk about it, that they know, and the understanding is that they want to be exposed to as much as possible, but they understand that they can't be proficient in everything. And you need ongoing training. I think the problem is that there are few programs out there, handfuls of programs. I mean, I think in terms of endobariatrics, I think maybe there are 2 in the US. And I think, if in terms of third space and advanced resection, dedicated fellowships for that, maybe a couple, like a few, less than 12 is my understanding. So very few programs have adopted any kind of evolution in their programs. And we just continue to tell fellows that you won't be proficient in these procedures and you kind of have to go off on your own as an attending to have ongoing mentorship and, perhaps either industry-based support or, if you have a colleague in another part of the country or outside the U.S. to help support you. So I think that's suboptimal to say, and we've got to evolve. And yeah, I guess the question is, number one, do fellows, if you're focusing on third space and advanced and resection, do you have like a luminal focus? Do you have to go through standard EUS and ERCP training? The even bigger question is, do you have to go through general GI training? I think, some people that may need to be abbreviated. So, uh, yeah, I think overall it requires revamping.
Yeah, for sure. I mean, if I was king for a day, I would say general, and this may not be super popular with a lot of the ivory tower institutions out there, but general GI goes at 2 years. We don't make people do a full year of research during their general GI fellowship. We offer that as a third year option, or your third year is your interventional option, or your IBD, or your hepatology, or whatever it is. So 2 years for general, 1 year for research, interventional hepatology, whatever, and then the additional year for your endobariatrics, your endohepatology, your whatever, whatever the subspecialty is, because that's what I would do if I was king for a day, but I'm not, and um, so let's talk a little bit about another important thing. You're an interventionalist, you're a woman, and there's not a lot of, I mean, there are more today, but when you were coming up through the ranks, there were not a lot of mentors or people or women in the space. So kind of let's talk about the challenges that you've faced carving out your space in a kind of I mean, let's just call it a male dominated field of medicine for many decades. So what are some of the challenges you face, both visible and invisible?
Yeah. I don't like to complain. And I think that, what I would say is, it is surprising, even at that point, some of the hurdles that I think those, similar to me experience probably. I'm sure it's definitely not independent to me. I put my head down. I put my hair back in a ponytail. I tried not to draw attention to myself physically. And I tried to be a hard worker, and I wanted to be recognized for the work that I did. Um, and I still feel that way. And I think, most of us, I'm sure, feel that way. We want to be recognized for our work and our accomplishment. Um, I would also say that, yeah, there weren't a lot of women that were, so in advanced endoscopy. I was lucky to work, closely with a couple in New York. Reem Shariah is only attending with me in my advanced endoscopy fellowship at Mrita Sethi. I had, had the opportunity to work with her a bit, and that was lucky. Geographically, I think a lot of people my generation probably didn't have that, so I was fortunate to see that they could do it. But I think, the way to handle it is not really to look in retrospect and maybe, think about struggling, but more so just looking forward to give opportunities to women, give back. People open doors for me. And so it's my responsibility to do the same. And, just trying to be, I just really want to be a positive influence, be a big cheerleader for women who are going through advanced endoscopy. And like I said, there are a lot of, you can do what you want in your career now. It's not necessarily the hours that I work or, things like that. So I think the opportunity is there for women. There's opportunity to have families. I think it's even smaller cohort of women who have families in advanced endoscopy. And actually we're trying to kind of connect that group of women as well for support. But I think, the hurdles are being slowly overcome, and it's those of us who are getting through it, sharing how we did that and seeing the younger women.
No, and I have to, you mentioned Amrita, and I have to say, she's done, and Reem and Uzma, they've done amazing things to help women in interventional endoscopy. In fact, I was at DDW, I think 6 or 7 years ago when it was at DC. Well, one of the times it was at DC, and I had a general GI fellow with me. And we had no women faculty at the time, so she wanted to do an interventional. She was hanging out with us at this Olympus event near the White House up on a rooftop, and Amrita was having a drink with a friend, and I just kind of walked in and interrupted. I go, "Hey, this is Shruti. This is Amrita. Shruti wants to be an interventionalist. Amrita's an interventionalist. Talk." And I walked away. And they are still in touch. And she mentored her. And I think it's really important when people do give back. So I think it's and I think it's a really good thing to do. And I see a lot of the things that are coming out, like women in endoscopy, and I think was it heels and scrubs or something like that. I see that all on social media, and it's a good positive way for people to kind of encourage and grow the field that way. Because I do think that when we mention diversity, we always think about diversity historically as like racial diversity or minorities and whatnot. But I think we forget that women are a minority in GI for sure, and they need to be. We need to get more women involved, because I have patients who won't get scoped because they don't want a man doing it. So I think we need to get, and that's 50% of the population. So we need to kind of mirror our population as well. So you're a mother, as you mentioned. So how do you balance that? Like, how do you manage your time, getting your kids to practices and homework and, all those things? So how do you balance a really demanding field like interventional endoscopy and a really demanding second job as a mother? So how do you balance those two things?
Yeah, not well. No. I personally, I have chosen, and I realize this now as I age. I chose, a demanding job specifically, and I took on administrative roles, and I really love traveling and doing teaching and connecting with old friends and new friends. And I like being part of societies and things like that. All of that adds up to many, many hours of work. And I realize that I choose that, and not everybody in advanced endoscopy is. So there's that. And I tell my children that when they say they don't want to go into medicine, I'm like, but not everyone works the way that I do. So I do choose that. And as a result, it's very hard to balance home and work. And there is no balance. And I think the first thing for everyone to understand, especially young women going through this, is there's an illusion that you can do it all and do it all well. And that's not the reality. And I would say I have a team at work, literally a team who make me look good. And I have a team at home who also make me look good. I could not do or accomplish everything that I do by myself. And, at home, it's my husband who is my biggest support and kind of allows me to have this crazy life. His job is, it's much more, I guess, regulated than mine. He has very routine hours. He's home early, by 5:30. So, he really can take the brunt of the weeknights. And I'm 110% on the weekends. And when I guess it's just a little bit hard. My schedule is kind of unpredictable based on cases and things like that, or evening meetings and everything. So it's, while I show up a lot, it may be at the last minute that, like, okay, I can come to the lacrosse game. And my children are big sports enthusiasts. And so, like, we're traveling every weekend for them. But so I just don't think there's a great balance. There are times when I've disappointed my family by not being there. I know that. There are times that, like, I'm sure I've disappointed my partners that leave or something, or ask for support. But I would say, overall, I do the best I can. And it's really because I have a lot of support, both home and work. And the thing that I would say is that, and what I'd say to, like, young mothers specifically, it's hard. You have so much mother's guilt. I don't know if that's put on us by ourselves, by others. I think mostly ourselves, to be honest.
Yeah.
And, there were times when my kids were younger, and I would have to make hard decisions about where, showing up for things. And I made stupid mistakes, like showing up an hour late to bubble night, and kids were crying. Gosh, I have so many memories and things that, like, kids say hard things about you not being at school at 10 o'clock in the morning for their project or whatever, because you're in the middle of a busy work day. And that's like a knife that goes so deep. But as my kids age, I can say that they're verbalizing to me now what I always hoped, is that, they would appreciate what I'm doing, and that they would see that it's an honorable life, and that they'd be proud of me. And I think that all of their experiences and mine has made them very independent. So it takes a long time to kind of get through those younger years that are all, hard. But I think we come out in the end, on top. And I've always had quality time with my kids is my focus. Yeah.
No, I agree. I think, when the one thing, because my wife is a physician as well and works very, very long hours at times. And I think I see the same things that you're saying. I see that when with which her experiences were, and it's tough because I do think humans and women specifically tend to have this expectation that I'm the motherly figure, but it's not just people doing it, it's also societal expectations, right? Like the mom's supposed to do this, the mom's supposed to be that. And you were getting away from that as the world matures. But I think I grew up in a very traditional Indian household and the dad did the work and the mom stayed at home, or the mom worked, but it wasn't to the level of what the dad was doing, those type of things. And I think that's just something that's ingrained in us as humans. So I think there's always this kind of guilt, mother's guilt, like you called it, that happens. But hopefully that's improving, and I think the kids understand that. And, I have a daughter and she's always seen her mom working. So I think that's what she's going to do. She knows nothing different, that mom works hard, dad works hard, and I'm going to work hard. So I think that's how you change it, by doing what you're doing. So we talked a little bit about mentorship. Just kind of as we're wrapping up slowly, like what are some of the misconceptions about what mentorship should look like in GI or interventional endoscopy? Like what are some of the things that, people expect a mentor should be doing, and what is really kind of your view on that in general?
Oh gosh, that's a tough question. Uh, I've been so lucky with my mentors, really. Definitely wouldn't be here without them. I think that there has to be, mentorship is not necessarily about advancing, the responsibility of the mentor to advance the mentee's career. That may be, an advantageous part of it. But I don't think that's necessarily the responsibility of the mentor. It's more guiding them and giving advice and whether that's research support and everything, but it can't be without work on the side of the mentee as well. But I think most of the time in a successful mentor-mentee relationship, ideally what you're getting out of it is both professionally and personally rewarding, which has been for me. I've been extremely lucky that still close with my mentors, and they still support me in my career development today. And we've evolved from those relationships into colleagues and family friends, and that's a successful relationship.
And yeah, I look at it the same way. I say, a mentor's job is to walk you to the door, but it's your job to walk through it. Like I think they get you the tools you need to get you where you need to go. And then what you do with that as a mentee is completely up to you. I mean, that's how I would look at it as well. And what's the best piece of advice you ever received? If you can lean back or think back to one piece of advice you got from one of your mentors, what would that have been? And if you can't think of one, what's the best advice you ever gave a mentee?
Okay, guy, nothing's off. I don't know. Hard advice from my mentor is, in times when you're inevitably choosing, between work and home and your family many, many times in your career, and the answer I got was choosing your family. And we all know the reality of that. It doesn't happen every time. But it's the soundest advice that I probably have gotten, that every time, that's what you're always coming back to. I think at work, we're all replaceable. That's the reality of it, but you're not replaceable to your family. So those big decisions, it always goes back to the family, even if it's a hard one. And I think, what I offer myself is, I don't know, we talk about this in fellowship interviews and when people bring up mentorship, and, I say that, when you're working with me, you see how I manage everything at work, and you see how you also hear all about my family, and how I think it's important for everyone to kind of see how we handle it day to day. You'll see me fail. You'll see me have big wins at home. You'll see me have failures at home. But it's okay, and that's part of it. And I hope that seeing that is real for them rather than giving, unrealistic expectations.
No, and I think that's perfect, because I say the same thing to my fellows when we were training them, is that be there for the family. But here's the thing: if you have 10 days, and if you can make it work out for the kids or the spouse, 6 or 7 of those days, that's a win, right? I mean, there are always going to be 2 or 3 times where the case goes long, or the meeting goes long, or whatever the case might be, and as long as you're there a lot, and they remember that, that's what's important. Because I think, and I always use that example about us all being replaceable, that if one of us were to die, the hospital will have a cookies and lemonade reception the next day. And the day after that, your job's being posted on LinkedIn or something like that. So, it's something really important and cool. So as we kind of tie up, we talk a lot about societies. I always encourage people listening to the podcast to join a society or more, whichever one that speaks to you: ASGE, ACG, FIGHT, AGA, whatever it is. But what have these societies kind of meant for you personally as you've grown in your career? Like, how have they offered you value, and what do you like about that?
I think what I like the most about it, truthfully, are the people that I've met and had exposure to as a result. That's the highlight for me, is just, friends like you. Seriously, that's, I may not have had the opportunity otherwise, so that's definitely a highlight. I think one of the things that that really changed a lot for me, I guess if anyone's listening, is the ASGE Gold program. It's the GI leadership program. And I was so lucky to have an amazing gold class. I call them like solid gold. I'm dating myself, but they're solid gold. And I have just loved the opportunity to get to know them personally, professionally. There's collaboration. There are 3 of us who have gone on to be chiefs of our division, and we collaborate together or commiserate together on things. What an awesome opportunity it was for me to meet people across the country that I wouldn't have otherwise, to help with leadership advancement, but also to get connected within the ASGE, because, gosh, there are a million wonderful gastroenterologists that want to be part of the ASGE, and it is like hard to get recognized sometimes, hard to get on committees sometimes, and this opens doors. So if any of that speaks to anybody who's listening, I would definitely look into that program.
And I could put a link in the description of the podcast for anybody interested. So before we finish, I always have a mental health PSA. So for anybody listening to the podcast, if you're struggling with work or stress or anything like that, just reach out, speak to people. I mean, my email is always open, but reach out to people, speak to mentors, friends, but just kind of talk it through. And there's a lot of apps out there like Better Health and all those things, which they're not sponsors, but those are really good things to look into if you're struggling. So with that, Jess, I want to say thank you so much for your time. I know, as we've talked about, life is busy for all of us. So for you to be able just to cut out an hour of your day, this has been awesome. So thanks again. And, look forward to meeting you at the next meeting. Are you coming to ACG, by the way?
I'm not sure. I got a course right afterwards in Mexico, so we'll see if I can make up.
Making it, yeah. It's in Phoenix in late October. It's I've taken the whole week off, so we'll be having fun. So
I'll be then. Thank you for the opportunity. It means a lot to be able to just sit here and talk and get to know each other even better. It's really, really special. Thank you.
no, thanks again.
Please hit that like button and that subscribe button.